Good morning, everybody. I hope that you are not yet saturated with the cardiovascular basic science. So we are continuing with the cardioprotection session. We have two excellent speakers, and we start earlier so we can have either more questions or longer coffee breaks. So the first speaker is Gerd Heusch, and the podium is yours, please.
Okay.
Oh, by the way, one more announcement that at the first coffee break, there will be a group photo, which is at the tent somewhere there. Okay, so don't escape, please.
Okay. Thank you, Peter. Good morning, everyone. I'm going to introduce the topic of cardioprotection to you. So if we examine what cardioprotection really is, it's now customary to look at Wikipedia first. And the definition on Wikipedia actually says that cardioprotection covers everything that acts to preserve or the heart from injury or to actually prevent it. And this is a definition that goes back to a definition earlier made by a true scientist, by Wolfgang Kübler, who just passed away a few weeks ago. Having said that, cardioprotection, preventing injury from the heart, obviously comes with a number of endpoints. And I've listed the most important clinical endpoints here. So it would protect the heart from arrhythmias, it would protect the heart from loss of contractile function, and most importantly, acutely, it would also prevent the heart from undergoing cell death. And cell death and the quantity of cell death is obviously another word for infarct or the extent of infarct. I will come back to that cell death. And just at this point, I want to mention that cell death not only relates to cardiomyocyte cell death, but there can be other cellular compartments in the heart that also undergo cell death. And eventually, and more importantly, I say that, for the clinical outcome, there is a more long-term endpoint, which is the remodeling process, the eventual loss of contractile function, and the development of heart failure that can result from myocardial injury. Cell death, I've mentioned already, is the most robust acute endpoint, or in other words, the quantity of cell death in terms of infarct size is what we usually measure both in experimental studies and in clinical studies to look at the acute effects of a cardioprotective intervention. The clinical background is depicted here. The amount of cell death, or I use the other term again, the infarct size, is actually a major determinant of patients' prognosis. And the prognosis from acute myocardial infarction is actually not so good, despite of what you read in most papers. Even in a well-controlled randomized clinical trial, very recently in the New England Journal by Michel Ovise's group, the one-year mortality from myocardial infarction was 7%. And then keep in mind, a randomized controlled trial is not the real world. The real world is much better seen in registries, where non-academic centers also contribute their patient cohorts. And in a large registry from the Scandinavian countries, the so-called Sweetheart Registry, the one-year mortality was 15%, 1 year after myocardial infarction, which is not really good. And one major determinant of that prognosis is actually infarct size, no matter whether you look at that with enzymes or with MRI imaging techniques. Now let's go back to the basic science. This is seminal work that was done many, many years ago, more than 40 years ago, by Bob Jennings in a pathological experiment that was done in dogs. I emphasize this is in dogs, that is large animals that have a thick wall in the myocardium as human beings have. The rodents, like mice or so, would be totally different and very difficult to extrapolate with respect to these findings to a human heart. But the dog heart is actually very nicely fitting to what we see in the human heart. And we start out to the upper left with a totally intact coronary circulation with an intact myocardium. Then there's a thrombus occluding the coronary artery in the upper right, and that creates an ischemic area at rest which is no longer receiving blood supply. Then keeping that artery occluded for 30 to 40 minutes, we see a tiny little bit of an infarct developing in the center of that ischemic zone and mostly in the subendocardial layers of that ischemic zone. And with progression of time, that little infarct progresses. It progresses from the center to the borders of the infarct, of the ischemic zone, and then also progresses transmurally from the inner to the outer myocardial sides. And after something like 6 hours, more or less the entire myocardium that has been ischemic has undergone cell death, necrosis, infarction. The time course is somewhat different between different species. What we can tell from experiments and clinical observations so far, that is studies in dogs and in pigs are probably most closest to the clinical situation. I say that as a side note for those of you who are interested in zoology. Actually, the primate hearts are very different from the human hearts. Primates have a very, very good tolerance to ischemia. For instance, if you take a baboon and occlude a coronary artery, after 90 minutes of complete coronary occlusion, there's very little infarction. So other than what you would think, the primate is not the best model to look at what happens in humans. It would be rather dogs or pigs to be used for that. Now, what do we do if the coronary artery is occluded? Almost everyone knows nowadays you have to reopen the coronary artery. But that's not such a really established finding for many years. In fact, the observation that reperfusion, that reopening of an occluded coronary artery would rescue the myocardium from observation is not even 50 years old. And these are studies that were done by Rainer Schulz and my own former mentor in San Diego by John Ross, published in JCI in 1972. And this was actually the first study ever that showed that if you compare a persistent coronary artery occlusion in the upper part, or you reperfuse, reopen the occluded coronary artery after 3 hours of occlusion, then that the creatine kinase content of the myocardium as a sign of viability, of membrane integrity, would stay higher with reperfusion than if you not reperfuse, where it would continuously decline and be released into the bloodstream. This is a pioneering observation, and it dates back only to 72. Within 10 years afterwards, there were clinical trials, the GISI trial, the ISIS trial, that have actually used thrombolysis with either streptokinase initially, then urokinase, then TPA, and nowadays, as you all know, in most instances, at least in the so-called Western countries, it would be an interventional reperfusion that is catheter-based. But, you know, as much as it is obvious to all of us now that reperfusion is the way to go for a coronary artery occlusion, that's not so long ago. I mean, I started medical school in 1972, and when I started medical school, a patient with myocardial infarction would be put into bed and left there for 6 weeks, and you would not reopen the coronary artery. You wouldn't even want to touch it. So this is a really different world now. Having said that about reperfusion, reperfusion is a sort of a double-edged sword. It salvages the myocardium, you have seen that before, but then again we know nowadays that reperfusion adds additional injury to the myocardium that has already been injured by the preceding ischemia. And this is a schematic slide that David Garcia from Barcelona has nicely put together. It shows that during ischemia, there is an increasing, almost linear increase in cell death over time, which is the gray part of that slide. And the only way to stop ischemic cell death is just stopping ischemia, reperfuse. But then, on top of the ischemic damage that has occurred, a separate additional component of injury that is also killing cells, that is contributing to cell death, that is the red part, the reperfusion injury. And so the final damage to the myocardium is a composite thing of ischemic damage that you can terminate by reperfusion, and reperfusion image that you buy with reperfusing the myocardium. Infarct size as a major determinant of patient's prognosis has a number of determinants. Of course, the primary determinant is simply the area at risk, how much myocardium is actually malperfused. If there's a little tiny area that is not receiving blood flow, the infarction will also be very tiny. If it's a large area, and this happens mostly if the left anterior descending coronary artery that is perfusing the anterior side of the myocardium and the apical side is occluded, then the infarction will be large. It depends, of course, how much residual blood flow you have. Sometimes the coronary artery is not completely occluded. There's some remnant blood flow going the antegrade way. And if you have a long-standing coronary artery disease over many years, there has been the development of a collateral circulation through angiogenic processes, and that collateral circulation will supply some blood even if the antegrade pathway through the coronary artery is occluded. And finally, as we have seen before, of course, the duration of the coronary artery occlusion is important, and you want to reperfuse the myocardium as quickly as you can. Now, what can we do apart from reperfusing the myocardium as quickly as one can? And this is the paradigm of cardioprotection on top of early reperfusion. And I mentioned that again, on top of reperfusion. This was an experiment which was done by Chuck Murray, who was a doctoral student at the time in the laboratory of Bob Jennings. And he was assigned to a totally tedious, stupid project. Bob Jennings assigned him to a project to look at the question whether one long occlusion would cause the same damage as the same time of occlusions being interspersed with little reperfusions in between. And the outcome was supposed to be loss of ATP, not even infarct size. And while Chuck was actually experimenting with this model, he had some very interesting observations that nobody would believe. And you see them in the protocol. What he did here is he had a 40 minutes coronary artery occlusion in the dog model, which caused about an infarct size of 30% of the ischemic zone. And if he added a few more cycles of ischemia, which were brief, however, only 5 minutes, then you would expect there's additional damage because there's more ischemia. But the opposite happened. There was a drastic reduction in infarct size. And he couldn't believe that, and it actually took his mentor, Bob Jennings, to actually emphasize this phenomenon and make something out of it that is so obvious to all of us now. Because what this shows is that small, non-lethal bouts of ischemia and reperfusion can actually activate a protective program in the myocardium that once activated can actually protect the myocardium subsequently from a larger damage. And this is what you see in the reduction of infarct size. I emphasized, and I emphasize again, this is a preconditioning intervention on top of reperfusion, because what most people forget is the right part of that article. If the coronary occlusion was not 40 minutes in duration, but in fact 3 hours, that is, the reperfusion was delayed until 3 hours, the entire preconditioning effect was gone. So you can only precondition if there is eventually reperfusion. So you have to add the cardioprotective intervention to early reperfusion. Only then does it make sense. And Derek Yellen, Sean David's boss, he was the first who actually saw the clinical application of that. Together with surgical colleagues, he actually did studies in the right part where patients underwent a coronary artery bypass operation, and he could convince his colleagues at the time to actually occlude the aorta, not the coronary artery, briefly twice before the CABG operation was actually done. And he could show that, in fact, the ATP content was better preserved, and he could also show that the troponin release during that cardiac operation was attenuated, thus providing evidence for cardioprotection. And there were other studies that used balloon inflation to dilate a coronary artery stenosis, where it showed that if you did repetitive balloon occlusions, that on the second and third occlusion of the coronary artery to dilate the stenosis, EKG changes were less pronounced than on the first one, again reflecting somewhat that a protection was going on. This is an update, April 29, 2019, on all the clinical studies that I could trace in the literature on ischemic preconditioning. I'm using that format throughout my presentation. If you look at the zero is actually where the mean value of the control group is. The gray bars around the zero are presenting the standard deviation in the control group. And then the treatment group is the colored data points. Yellow for the significant ones, red for the non-significant ones. And every data point that is leftward from the zero, from the control group, is actually giving evidence for reduced infarct size. Everything right is a larger infarct size. So you can tell that the majority of studies, and many of them also significant, showed a reduction of infarct size parameters. But then again, being critical here, this is only during coronary artery bypass surgery, because for preconditioning, you can use that only in a planned, in an elective intervention, and not in an infarction where you never know when it happens. The group and the cohort sizes are fairly small, and the parameters are largely indirect, that is creatine kinase or troponin release. That's not truly an imaging point. So the clinical relevance of ischemic preconditioning is probably relatively small, just because it can be applied and used only in elective interventions. So ischemic preconditioning per se is, in my perspective, more of paradigmatic value for understanding self-protective programs in the heart, rather than really being clinically applied. This is entirely different for postconditioning. Postconditioning comes after coronary artery occlusion and after reopening the coronary artery occlusion. So this is, of course, obviously relevant to a patient undergoing myocardial infarction and having the coronary artery interventionally reopened, because then you have the catheter in the coronary artery and you can just occlude the coronary artery for a few more times by just inflating briefly the balloon. And the experimental model for that was again done in dogs to the left side, and just in sort of an analogy to what you've seen with preconditioning before, there were now 3 cycles of ischemia following coronary artery occlusion and reperfusion, and again the infarct size was reduced, and that was first applied only 2 years later. Look at the data below. The dog publication in 2003, the clinical paper 2 years later in 2005, in a group of patients where Michel Ovis actually did a post-conditioning intervention in patients with an acute ST segment elevation infarction, and he used creatine kinase as the measure of infarct size, and that was reduced by about 40%. This is the format that I promised before. You can see now we have a much larger sample of studies. We have studies with much larger cohorts. These are truly ST segment elevation myocardial infarction, so the real thing, not an elective intervention. And the data are more solid in the sense that they are not only based on enzyme releases, but also on true imaging of myocardial infarction with either SPECT techniques or MRI techniques. And as you can tell, not all studies are positive, but again, the majority of studies shows significant data towards the left, indicating that post-conditioning can be used in patients to reduce infarct size. Now the most funny and probably most important phenomenon on the preconditioning scenario is the remote preconditioning. In the initial study by Karin Pschücklenk, she did a very funny experiment. She occluded briefly for 4 times 5 minutes the left circumflex coronary artery in dogs, but then subjected the left anterior coronary artery to a sustained longer occlusion. And somehow these two vascular territories interacted because, again, the circumflex occlusion upregulated a protective program that was operative in the LAD perfusion territory, such that infarct size was again reduced. And this was initially, I remember when she first presented that at American Heart, we all thought this is a laboratory curiosity. What's the sense of that? I mean, two vessels interact. What do you make of that? But very quickly thereafter, it showed that such a protective effect could be elicited at much larger and longer distances. So another study came up briefly thereafter where the renal artery, so the kidney was occluded, the kidney was made ischemic, and again, the heart was protected. So the upregulation of a protective program in the heart is operative at much longer distances. And that brought us to actually develop interest in the phenomenon of remote conditioning. And nowadays, the remote conditioning phenomenon must be regarded as a very comprehensive, systematic reaction of the entire organism. It can be elicited from a variety of organs, which you see at the left. So you can elicit protection from the brain, from the heart, from the liver, from the kidney, from the gut. Then the stimulus for eliciting such a remote conditioning program is not necessarily ischemia reperfusion. You can also elicit such protective program by another injurious stimulus, such as simply cutting the skin at a certain area, or even more technically, you can just electrically or chemically stimulate sensory nerves in a given area and elicit the phenomenon. Now, the actual enigmatic part of it is, how does an injurious stimulus in one part of the body get to a very distant other part of the body to elicit protection there? And what we know nowadays is there is both a neuronal component through sensory nerves and the central nervous system, and a humoral component by factors that are being released and reach those other organs. And again, the target organ does not necessarily have to be the heart. We have evidence now that also other organs are protected by this phenomenon, like the brain, the skeletal muscle, the lungs, and so on. So it's truly a systemic response. To the left part, you see again the experiment by Karin Pschücklenk that I called before a curiosity as we perceived it initially. But that was again translated to a very reasonable clinical setting by Derek Hausenloy. And he again used the situation of coronary artery bypass surgery, where during surgery the heart is put under ischemic cardioplegic arrest. So it's a very controlled ischemia setting that you have there. And he used a stimulus which actually meant to make the arm ischemic. And he did that in a very interesting way, non-invasively, by simply inflating a blood pressure cuff 3 times for 5 minutes to 200 millimeters of mercury and then releasing it again. So the arm was made ischemic 3 times for a very brief time. And what he saw is that the troponin release as a measure of injury to the myocardium was actually sizably reduced by that intervention. So he could show that a non-invasively induced ischemia reperfusion to the forearm was actually protecting the human heart during coronary artery bypass surgery. More importantly, because it is a myocardial infarction scenario, Hans-Erik Bodker, who is depicted in the right part of this slide, took advantage of a special situation in Denmark. Denmark is a relatively small country, and they have politically decided, to not do coronary interventions all over the place in all small hospitals. They have only 3 centers where they do coronary interventions, And they have a very sophisticated transport system for the patients, so they are transported into those 3 centers by helicopter, by ambulance, and so on. And what Hans-Erik did is actually he used that transport situation, and during the transport of a patient to an interventional center where he would receive reperfusion, he inflated the blood pressure cuff again to possibly protect that patient from infarction. And then the patient actually came to the interventional center, got a reperfusion, and so on and so on. And 4 weeks later, they took an image of the myocardium. And of course, there is a large scatter. But if you look at the yellow data points, it shows that those patients who had received the intervention during the ambulance and helicopter transport actually had smaller infarct size, saying that this non-invasive procedure actually reduces infarct size in patients with ST segment elevation infarction. On a secondary, and I have to emphasize, on a secondary retrospective analysis, this study from Denmark also showed that a number of clinical endpoints, notably mortality or readmission for heart failure, were also reduced. So it had also prognostic impact, not only an imaging result in terms of infarct size reduction. And this is again my presentation of a forest plot here. And as you can see, there is a number of studies that are not significant, but there's also a somewhat greater number of studies that showed a reduction in infarct size. And now the patient cohorts are quite big, sometimes several hundred. The evidence is not only from enzymes, it's also from imaging data with SPECT and MRI. And this really relates to ST segment elevation infarction. You remember the infarction that carries a 1-year mortality of 15%. So to reduce infarct size does mean something in these patients. We in Essen have also used the paradigm that I've shown to you with Derek Yellen and Derek Hausenloy before, that is the bypass surgical operation. And we basically repeated what Derek Hausenloy had shown. If you inflate a blood pressure cuff in those patients, you can actually reduce the troponin release during bypass surgery. More importantly, however, we not only showed that the acute damage in terms of troponin release is being reduced, that is the left lower part of the slide, we also showed that this had prognostic impact. And in the original paper in 2013, we showed that the complication rate, the major adverse events, they were reduced over a 4-year period. And my collaborator Petra Kleinbaumer just published a reanalysis where patients had been observed over 10 years with a 99% follow-up. And we could show that all-cause mortality from that single protective intervention during bypass surgery significantly reduced mortality even after 10 years. So it's a long-lasting clinical benefit that you can have from just a single cardioprotective intervention in this particular case. However, now comes the water in the wine. We showed that the effectiveness of that protective intervention very much depended on the anesthesiological protocol that we used. And as you can see in the left part of this slide, the reduction in troponin was largely was very much seen if the anesthesia was with isoflurane, but it was abrogated and abolished when the anesthesia was with propofol. And this initial finding that we published several years before was actually confirmed by a large meta-analysis where also people showed that the TIVA is total intravenous anesthesia, mostly with propofol, that abrogates the preconditioning effect. So you have to use a volatile anesthesia, either enflurane or isoflurane, to actually make benefit from that. And this for us necessitated a better understanding. Why does propofol abrogate protection? Why does isoflurane permit that? And this brought us into mechanistic studies to understand the signal transduction of that phenomenon much better. So this is a more general scheme of the signal transduction. What is depicted here is an ideal cardiomyocyte. with the sarcolemmal surface and a number of receptors for various ligands that have been by someone in some experiment in some species shown to be associated with cardioprotection. These receptors are being activated by their ligands, then activate a number of intracellular signaling steps, mostly kinase signaling steps, which can be very grossly classified into 3 clusters. The green one is a pathway that involves a NOS, that is NO synthase, PKC, and protein kinase G. The yellow cluster is the classical survival kinases, AKT, ERK, and then there's also a cytokine-induced third pathway which involves the STAT system. And all of these kinase signaling systems that are activated in the cell somehow converge on the mitochondria to actually make the mitochondria work better in the sense of less ROS production and better respiration. So this is how we do our experiments. I mentioned earlier that in my perspective, the best models for looking at myocardial infarction in humans are either pigs or dogs. We mostly do pig studies, and to the left you see a typical experiment, chest being opened, pericardium being opened. You look at the anterior surface of the heart. You see the occlusion on the left anterior descending coronary artery, and you see little holes where we take biopsies from which we can do biochemical measurements or Western blotting of enzymes. In the tip of the myocardium, we insert a catheter to measure left ventricular contractile function, and then we measure blood flow with the microsphere technique, that is injecting colored particles into the left atrium, and taking a reference sample from the aorta, we can calculate blood flow to a given myocardial area. This is how we look at the remote conditioning procedures. We do remote conditioning either before, that's the upper part of the protocol, or we do it during coronary artery occlusion. The preconditioning, the remote preconditioning, as we have discussed before, is useful only in elective settings, such as surgery. However, the occlusion of a distant part of the body during coronary occlusion is a procedure that can also be applied during myocardial infarction, like in the Denmark study. And what we do is we take the hind limb of a pig and just occlude it with a tourniquet 4 times for 5 minutes. On the right part you see the reperfusion, and we really occlude the leg. You can see the skin mark where the tourniquet has been applied before. So what we see with a typical preconditioning protocol at the left is that, again, infarct size in our pig model is being reduced. A remote preconditioning effect, as was seen in patients before. Now, the most interesting question initially for us was, how does the protective signal arrive from the leg that is being subjected to ischemia reperfusion to the heart? And we were initially interested in the transfer of protective factors through the bloodstream. And what we did is, after the preconditioning protocol, we took arterial blood samples, derived plasma from these arterial blood samples, and then infused the plasma into an isolated perfused red heart. So a different individual, a different species, and we wanted to see whether the pig leg would actually release some factors that could actually protect the isolated red heart. And what you can tell is it does. So infarct size in the red heart was reduced, indicating that indeed remote conditioning in one species, in one individual, releases cardioprotective factors into the blood that can be transferred to a different species. What is the signal that is important for that? In our hands, in the pig heart, the protection was associated with the STAT3 pathway. We did Western blotting, you see that in the upper part from the biopsies that we took, And only with a remote preconditioning protocol did we see a STAT3 activation and a reduction in infarct size. And if we used a blocker of that STAT3 and abrogated the activation of STAT3, we also abrogated the protection in terms of infarct size reduction, indicating that indeed the STAT3 activation in the pig heart was necessary to induce protection. So how about the protection in the rat heart, to which we transferred the protective factor? The white and yellow shows actually the difference between placebo and the preconditioned pig plasma. So we see the infarct size reduction in the rat heart. But now it's not only the STAT3 pathway, which when being blocked abrogates protection, but it's also, with using Wortmannin and UO, it's also the AKT-ERK pathway. So it's not only the transfer from one individual to another, from one species to another, but the two species have different signal transduction pathways to achieve the same thing, that is eventually infarct size reduction. I have mentioned before that there is also a neuronal pathway that is activated by protection. And we were interested in this neuronal pathway and the interaction between the neuronal and the humoral pathway of protection. What we did here is again induce remote conditioning, RIPC, and compared that to placebo, and again we saw an infarct size reduction. But then we were interested in the neuronal pathway, and in fact with vagotomy, bilateral cervical vagotomy, we could abrogate the phenomenon. So the vagal nerves are obviously essential to exert the protection. But more interesting, it was not only the vagal nerve, but it was the spleen that has a central role for this cardioprotection, because splenectomy, surgical removal of the spleen, also abrogated protection. And finally, more interestingly, if you did not remove the spleen, but just surgically denervated the spleen, that is the right part of the slide, also abrogated protection. So there is a neuronal component, there is a splenic component, and apparently the spleen needs to be innervated to actually exert the protection. And again, we did the same thing. We took plasma and transferred that to a rat heart. What you see here again is the same as you've seen before. Vagotomy, splenectomy, and splenic denervation in the pig also abrogated the transfer of protection to the rat heart. So obviously the final step of the neuronal activation was something that was humorally released and transferred to the rat heart. And this is the ultimate experiment. Indeed, the spleen is a mandatory organ for protection, because what we did here, we used an isolated spleen, activated that isolated spleen by a surrogate of vagal activation, that is carbachol, a muscarinic agonist, and then took the effluent from that isolated spleen after carbachol stimulation and gave that to an ischemic rat heart. And as you can see, a carbachol-stimulated spleen releases factor that then reduce infarct size in the rat heart. And this is how we perceive the signal transduction, the signal transfer at this point. If the arm is being made ischemic and reperfused remotely from the heart, the blue pathway shows humoral factors that are being released into the blood, go through the pulmonary circulation, and arrive at the heart to exert protection. But then there's also a neuronal component by sensory nerves that project through the central nervous system to the vagus. And the vagus not only activates something in the myocardium, it also acts on the spleen and makes the spleen release something that is then again transported humorally to protect the heart. So a very, very complex pathway, but it fits well to the very systemic body's response that we have here. And I mentioned already the Preconditioning is more relevant. That is a remote procedure during coronary occlusion, because it can be applied also in an acute ongoing infarction, and again it induces the same phenomenon. So how is the signal transduction in humans? What is the translation of our findings? We have looked for about 40 different factors in the blood of our surgical patients to identify something that could possibly be chemically used to induce cardioprotection. And that was a very disappointing study. The only thing that we eventually found is interleukin 1 alpha, which was somehow having a time course that could be associated with cardioprotection. So all these cytokines, growth hormones, everything you may think of, we had a shopping list of 40 factors, and all of them were negative. So at this point, we actually do not know what the circulating factor is. However, we see a response in the myocardium because our surgical colleagues, when connecting the patient to the cardiopulmonary bypass, they always could take a little piece of the right atrium for us in which we could do some functional studies. And we isolated mitochondria from the patient's right atria and compared again those from placebo and remotely conditioned patients. And as you can see, a variety of mitochondrial parameters became better in those patients. Respiration at complex 1, ATP production, calcium control were better in remotely conditioned patients, and ROS production was less. And this was also associated with better function. We actually did isolated strips of right atrial trabeculae from these patients and subjected them to an hypoxia reoxygenation protocol. And what you can tell is that the remotely conditioned myocardium starts out already with somewhat better function, and the better function becomes particularly prominent in the recovery phase during reoxygenation. So we have a better mitochondrial function and a better contractile function in the remote myocardium of these patients. And we were fortunate enough that our ethics committee permitted us to do a few ventricular biopsies as well. So with a true cut needle from the left ventricle, where really the ischemic myocardium was, we could also take some biopsies, and we could do that in a placebo group and a remote conditioning group before ischemic cardioplegic arrest and afterwards. And again, we looked for, I think, 35 different factors, kinases, cytosolic phenomenon, and the only thing that we found significantly different is STAT5. So very different from the STAT3, as you recall, in pigs and rats. In the human heart, nothing for the STAT3 signal. It was a STAT5 signal. So at this point, we do not know whether it's just another isoform of STAT in humans or whether this is a totally different function. This is the only signal that we could identify in human preconditioned myocardium on the ventricular level. Now, coming to the final slides, and before handing over to Rainer Schulz, how do we translate all these signaling findings and the infarct size reduction that is a nice surrogate to better clinical outcome? Because that's are two different things. The reduced infarct size is something that you measure with a biomarker or with an imaging procedure in the week after myocardial infarction. The patient doesn't sense whether he has less enzymes or a smaller infarct size. So it's not necessarily relevant to the patient's life expectancy or life quality. What is more important for the patient is the improved outcome, and the outcome over a much longer time scale. Does it have reduced mortality? Is there less heart failure? Are there less complications? And this is a difficult thing because many, many factors apart from reduction of infarct size impact on that. Medication, age, comorbidities, and Rainer Schulz is going to expand on that, so I'm not doing that at this point. What I just want to mention here is that all these factors can obscure and hide a potential protective effect in the sense if something makes infarct size smaller in the placebo group by being protected itself, such as a beta blocker, it will of course diminish the potential difference to the cardioprotective study under the cardioprotective intervention under study. Or the reverse, if something, remember the propofol, abrogates the conditioning pathway in the treatment group, then the difference between placebo and treatment group will also go. So this is not only a long-term problem for the patient, it's also a problem for the interpretation of the available studies that we have at this point. And I think what is very important to me with my current research now is, and I come back to what I said in my very initial slides, for cell death we have to think not only about cardiomyocytes. There are a number of other cellular compartments in the heart, like endothelial cells, vascular smooth muscle cells, fibroblasts, nerves, and so on, so on, so on, immunological cells. And as good as cardioprotection is, and as nicely as cardioprotection reduces infarct size, it does not protect all cells from injury. What we have recently done in our pig model is we have shown that the remote conditioning to the left nicely reduces infarct size, but in the very same pigs, it did not reduce the injury to the coronary microcirculation because the no reflow area was not at all affected. So keep that in mind. We have to look at different endpoints. And I've emphasized that in a number of recent articles. I originally mentioned already 7 years ago we should look at the coronary circulation. And with an editorial to another study that just appeared a few weeks earlier, I mentioned again, we have to be aware that infarct size is a surrogate. It's a short-term surrogate, and it's certainly not the only parameter that it impacts on patients' prognosis and clinical outcome. But I want to end not with a warning, but with a positive and optimistic perspective. And therefore, I'm showing this study from Portugal. And we have some people in the audience who are very closely related to the authors of this study. This is a study in more than 500 patients with ST segment elevation infarction. And to my best knowledge, this is the only available study where clinical outcome, not infarct size, clinical outcome was the primary pre-specified endpoint. And it's a nicely placebo-controlled trial where people underwent remote ischemic perconditioning during coronary occlusion on the leg rather than the arm. And what this study showed is that indeed the prognosis, the primary endpoint being cardiac death or admission for heart failure, was significantly improved over a 3 years time period. And even more importantly, on a secondary analysis, the two endpoints that were combined for the primary endpoint were separately significant. To the left, you see there's a significant reduction in mortality and a significant reduction in hospitalization for heart failure. And that is what ultimately counts for the humans, a long-term better life expectancy and better quality of life. After all, that's what we want to achieve. Thank you for your attention.
So, any questions, please?
Thank you for a nice talk. I have few questions actually. I'm curious about preconditions. I don't know what is the criteria selection for the patient to undergo preconditions, because for me it's preconditions maybe the kind of prevention, because myocardial infarction is somehow unpredictable. So what is the criteria selection for the patient to go preconditions, and how long it should be done in advance to give the protective effect for the patients? And the second question is, what is the...
Let's start with the first one. So, as you said correctly, we cannot predict when an infarction will occur. So the true preconditioning cannot be systematically applied to a patient. However, there is a number of patients that have chest pain, intermittent ischemia before actually experiencing a myocardial infarction. So they have, without having that artificially induced by us, they have a preconditioning episode before. We call that pre-infarction angina. And patients with pre-infarction angina have a better outcome than those experiencing sudden coronary artery occlusion. Then again, preconditioning cannot be reasonably used in patients with infarction. So you can use the postconditioning, and you can use the local postconditioning if you have a catheter in the coronary artery to reperfuse the occluded artery. But you can also do the perconditioning, that is, occlude an arm or a leg even before you occlude the artery. Remember the Danish protocol where they used the long transport time. And we have several colleagues now all over the world that actually recommend in their ambulance areas and their infarct registries to just inflate the blood pressure cuff more frequently.
And the second question is, have you ever done any exosome or secretome analysis to see what is the common factor between, it could be secreted between the preconditioned conditions, post-conditioned condition, and remodeling conditions? What is the common player between those?
I have not looked at exosomes. We have much better experts, Sean and Peter, to look at exosomes. But whatever we did, either hypothesis-driven or systematic, and I can tell you a little more about that, was mostly negative so far. We have done a lot of hypothesis-driven analysis because we were seeing very robustly that the STAT pathway was activated and it was causes for the protection. So there are two classes of molecules that actually are known to activate the STAT pathways. These cytokines and the growth hormones. And we have looked at anything that you could measure there and didn't find anything. And we have also used the proteomic approach, which is sort of a fishing expedition. And as you know, if you are not really sure what you are looking for, then you are looking for abundant proteins, and the very little one that maybe increased tenfold, it just goes undetected. So whatever we did so far didn't work out.
Hi, thank you for the excellent talk. I was wondering that since you mentioned that even non-invasive procedures like having a blood pressure cuff could help release those factors, so why shouldn't it be not done routinely even for normal people, so that it keeps on giving this cardioprotection? Sorry, I'm a basic scientist, so I don't know about if this is a relevant question, but shouldn't it be routinely done for everyone if it's helping in cardioprotection?
At this point, that's actually a reasonable proposal because it doesn't cost anything, it's non-invasive, and the only side effect that has been observed so far, and very rarely, is small petechial bleeding to the skin. But that occurs only, 2 to 3% of patients. I've done it for these fishing expedition studies many times on myself. It's just unpleasant to have the arm ischemic for 5 minutes. It feels numb, a little painful, but not really bad, and certainly much less worse than having a myocardial infarction. So people who are really undergoing a myocardial infarction and that intervention never complained about it.
So I was wondering, what about the metabolic pathway? Because you showed that the mitochondria were making a better job.
Yeah.
So why not thinking about fuel and the metabolism, not proteins? What could the spleen perhaps do something to have more fatty acids available for the myocardiocytes?
I wouldn't think about fatty acids because fatty acids are being burned at a relatively low efficiency rate. But there have been studies showing that certain ketone bodies and also certain amino acids may be protective. Well, it has been shown, I think, for glycine, and it has been shown for alpha-ketoglutarate in certain experiments, but the data, as far as I know, the literature were not very robust.
Could the vagal stimulation ask some specified cells of the spleen to produce fuel?
Possibly.
Because what you say is that you save those areas that are better perfused. You need to do nothing on microvascular perfusion, so it's metabolism, it's fuel.
certainly involves metabolism. I think at this point we do not have an evidence that it is, metabolism as a first step or as a primary thing, but definitely
It's a substrate.
Yeah, if the mitochondrial respiration is better, eventually it involves metabolism, obviously.
And availability of the substrate that the spleen might provide. I don't know how.
Yeah. But I'm not. I mean, personally, I do not think about a substrate when I consider the spleen. I'm rather looking for immunological factors. Well, that's the primary function of the spleen.
Yeah, just a comment since the question was raised about the exosomes, that we looked at the blood in rats and humans after remote ischemic preconditioning and saw an increase in the numbers of exosomes, although when we look at it more carefully we think it might contribute to protection but doesn't mediate the whole effect, which I can explain more in detail later. But can I just ask quickly as well about the study with Hans-Erik Bodka, the remote preconditioning in the ambulance? You said it was given some time before the reperfusion. Can you comment on whether you think it might actually protect against the ischemic injury in that case as well?
I think so. I mean, we have made the point in a study that I didn't show here. We also see when we do a preconditioning protocol in our pig preparation, we already see an attenuation of the ST2 elevation while the coronary occlusion is still on. So we think that the remote preconditioning, even if being done during coronary occlusion, should be as early as possible. And that goes along with other findings, like the Metocard study by Royer Evanes. I mean, the patients that had the metoprolol early on did better than those having it delayed. I think we may have been too focused not only on infarct size versus coronary circulation, but also on reperfusion versus ischemic injury. I think we have to think protection in a broader sense, time-wise and target-wise.
Excuse me, have there been studies in patients with unstable angina or non-STEMI? And also, could there be any protective base for stroke even? I mean, could this have even effects in patients with stroke, not in cardiovascular? Just cardiovascular.
Yeah, there's a number of studies showing the protective effect in stroke models in rats and other species, and there are some, I would say, promising preliminary data in showing a better outcome in stroke studies in terms of regain of motor control and cognitive development. I'm not aware of a study showing smaller cerebral infarcts in humans at this point. So I'm not sure about that. But definitely stroke is also benefiting from a remote conditioning procedure. I'm not aware of a study in unstable angina. However, unstable angina involves platelets very much and platelet leukocyte aggregates, and those are being reduced in number by the remote conditioning protocol.
Gerrit, coming back to the mitochondria, you mentioned that better ATP production is going along with better function. But we know that maybe early on ATP production can also cause hypercontraction of the cardiomyocytes leading to the cell death. So it might be a matter of timing that the mitochondrial function initially should be impaired to really protect the heart. And in this scenario, maybe the malonate treatment, which David Garcia did to impact succinate use within mitochondria, might be a good explanation for that.
I fully agree. I probably didn't specify that. Mitochondrial data that I showed from the right atrium were at baseline. These were baseline measurements, and mitochondrial function at baseline was better. And then we did only the contractile studies with hypoxia or reoxygenation on the trabecula. But we did not do mitochondrial measurements under hypoxia or reoxygenation. That was just the baseline that was better. And it was just to show that indeed remote conditioning can be traced in human myocardium as doing something there.
Thank you. Very excellent presentation. A quick question. Splenectomized patients could be a model in vivo human model of cardioprotection, and also another thing, spleen has been involved in blood pressure regulation. How is it involved also in this?
I may advertise, if you go to Circle Research earlier this year, I think January, I have an article in Circle Research, the spleen and myocardial infarction. And what I traced in the literature search, there is one study from World War II veterans that by whatever reason had a splenectomy. Several hundred patients published in the Lancet. And these patients with splenectomy had a higher death rate from myocardial infarction and stroke. So apparently from these very associative clinical findings, you could conclude that the spleen is really necessary to protect from ischemic events in general. I mean, it's an extrapolation of findings, but there is a clinical correlate to it.
Okay, thank you. I have a last comment on your question whether remote conditioning should be generally applied. This is my opinion that before doing this, we need large clinical trials which are still lacking actually, which can really subgroup some comorbidity patients. So far the safety looks okay, but we don't have enough clinical trials to say that. So that's why it's not commonly applied.
I somewhat disagree. Maybe that's an interesting discussion because it comes to the question of efficacy versus safety. I mean, we have enough data to show that it is safe. Safety trials are available. We just do not know whether it's efficacious. So even if it's useless, it's safe.
Yeah, I somewhat disagree on the number of patients so far studied, but that's the time we'll decide. Okay, so we have to move on. Thank you very much. Yes.